Good evening, everyone. Thank you so much for joining us. I see that we have a full house this evening. Thank you so much for making the time to join us today to talk about such an important topic. I'm going to go ahead and begin since we have a schedule to follow. Hopefully everybody can hear us. And if you're having any issues, if you would please, you can go into the chat and find Kirsten Ingraham and send her a private message. Just let her know if you're having any issues with Zoom. So welcome to the Duke Cancer Institute Office of Health Equity. This is our monthly virtual series, and this is Conversations with Our Community. The title of our presentation today, or our virtual webinar, is The Importance of Primary Care in Early Detection of Cancer. We have some very wonderful speakers today joining us: Dr. Anita Pisharody, Dr. Rosina Kilgore, or Rosie Kilgore, and LaSonia Barnett. So we will begin with our agenda today. We would like to welcome you today to our monthly series. We've been having these for about a year or over a year now, and we have been very fortunate to have had a successful event every time we've held one. So we're going to be going through three different important topics. First, Dr. Anita Pisharody will be going over why do we need primary care. After that, Dr. Kilgore will join us and talk to us about primary care, cancer screenings, and underserved populations. Following Dr. Kilgore, we'll have LaSonia Barnett, our Senior Program Coordinator at the Office of Health Equity, cover the piece on patient navigation and resources. Soon after that, we will do question and answer. So we will hold off on questions until the question and answer period. And you can see the times for everything here. We'll then go over the additional resources and upcoming events, and we'll close out at 7:30. So just to go very briefly over the Duke Cancer Institute's vision and mission, our vision is to excel as the leader in reducing cancer disparities through authentic continuity, engagement, and partnerships, and delivery of seamless cancer care, and the provision of outstanding and innovative research and resources to achieve optimal health in a changing and diverse environment. Our mission is to reduce cancer disparities and to promote health equity with the Duke Cancer Institute's catchment area through strategic initiatives that integrate these following core areas. So we have, and they don't go in a specific order, but our four core areas are community outreach and engagement, community-facing patient navigation services, health disparities education, and clinical trials education and workplace diversity. So first we will have our speaker, Dr. Pisharody. She is board certified in family medicine from Duke Triangle Family Practice. Dr. Anita Pisharody, excuse me, is a family medicine specialist in Durham, North Carolina, and has over 30 years of experience in the medical field. She was born and raised in India. She completed her medical degree at the University of Calcutta Nil Ratan Sirkar, also known as NRS, Medical College in 1990, and this was in India, and family medicine residency at Methodist Medical Center in Illinois from 1995 to 1998. Dr. Pisharody has been with Duke Primary Care for 15 years, and is the practice medical director at the Triangle Family Medicine for the last 6 years. She's affiliated with Duke Regional Hospital and Duke University Hospital. She speaks 4 different languages, which you can see here. And this is just a quote from her. We'll go to the next one due to time. Dr. Kilgore, Dr. Rosina Kilgore is an internist, pediatrician in internal medicine. She is at Lincoln Community Health Center located here in Durham. Dr. Kilgore received her undergraduate degree from Duke University in 2009. She has her master's in public health, which she received in 2015, and her medical degree from the University of North Carolina at Chapel Hill School of Medicine in 2016. She works in Durham, North Carolina, and specializes in internal medicine, pediatrics, and internal medicine. Dr. Kilgore did her residency in internal medicine pediatrics at East Carolina University, Brody School of Medicine, Vidant Medical Center in 2020. And her interests are in health inequities, child maltreatment, trauma, informed care, and global health. Her leisure interests are cooking, eating, dancing, and traveling. She currently works at Lincoln, like we mentioned, which is a federally qualified health center here in Durham. And these are the languages she speaks. Now I will turn it over to Dr. Pisharody. Thank you so much for joining us, Dr. Pisharody. And you can take on.
Thank you for having me. Can you all hear me? So first question that comes to mind is, why do we need primary care? I mean, many people may be wondering, why is it important that we have a primary care physician? We could just go to a specialist if there is a problem with the lungs or with the heart or with any other part of the body. But it is very important that you have a primary home or a primary care practice where you can go and start investigation of your problems. Next slide. Primary care is the first contact of a person with the healthcare system. Now, if you look at the healthcare system like a pyramid, we are at the base of the pyramid. So the best entry into the pyramid will be through the base. You come to the primary care provider's office and you talk about all your problems. You can talk about, any physical problems, mental problems, even things that sound like silly questions. This is a place to start. The primary care doctor or provider is the person who will sort out these symptoms, these problems that you have, and give you good direction, whether you need to go see somebody else, what you need to do at that point. Next slide, please. Primary care providers are specifically trained and skilled in comprehensive first contact, continuing care for persons with any undiagnosed symptom, sign, or health concern. We call it the undifferentiated patient, meaning you come in with a bunch of symptoms. We don't know what is wrong. You spill out all your problems to us. And that's when we say, okay, this and this and this seems to be together. I think this can be helped with this, or this can be monitored. And we go from there. It is not limited by problem origin. It could be biological, it could be a behavioral problem, it could be a social problem, organ system, or diagnosis. Next slide, please. Primary care includes health promotion, disease prevention, and health maintenance. So I was talking about people coming in with issues, with problems, with things that are concerning, bothering them. It could be a mental bother, it could be a question in their mind, it could be something physically bothering them. In addition to that, we also talk about health promotion. So if you come in just for a physical, we can look at your risk factors. We can tell you what you are at risk for. We can tell you what to do to alleviate that risk or decrease that risk and lead a healthy lifestyle. That comes under disease prevention. And health maintenance, we have certain tabs in most of us have electronic medical records. We have ways of knowing what age a person is due to get a certain screening test or not. We will tell you what is best suited for you. We will tell you what is not, so you don't get unnecessary testing. We give you counseling when you need it. We give you education when you need it. We diagnose and treat acute and chronic illnesses. So any of the acute conditions, starting from colds, flus, bronchitis, pneumonia, all these can be taken care of at a primary care doctor's office. We treat mental illnesses like, depression, anxiety, any situational issues, adjustment issues, parent-child interaction issues. We take care of all that in our office. We also take care of chronic diseases like hypertension, diabetes, which are not uncommon in the community these days. With the lifestyle we lead, with the exercise or our lack of exercise in our day-to-day lives, with the food that we consume these days, many of us are at risk for these chronic conditions. So we take care of these chronic conditions. We medicate you properly. We watch you. We monitor you for long-term health. So this is done to prevent complications in the long term. Primary care is performed and managed by a personal provider who collaborates with other health professionals and utilizes consultation or referral as appropriate. So in other words, you have a relationship with one provider, and that is what is most important. That provider knows you well, and you know that provider. You feel comfortable telling that provider what's in your mind, and that is the start of good health. Now, this provider is not, be it end all everything, but this provider will consult other providers like specialists, nephrologists, pulmonologists, cardiologists, neurologists. We communicate with all other health providers to make sure that you're getting the right care that you need. Next slide, please. Primary care promotes effective communication with patients and families to encourage them to be a partner in their health. Now, when you go to a primary care doctor's office, when you are referred to another specialist, a lot of times you'll hear the primary care telling you, be sure to ask these questions. Be sure to get this from the specialist. These are things the primary care doctor will prepare you for your visit with the specialist. When you do that, it ensures that you get maximum benefit from that referral or that visit with your specialist. That is important, very, very important. And also the other way around, from the specialist to the patient and to the primary care. So if the specialist tells the primary care physician that, this patient needs A, B, C, and D, the primary care doctor will make sure that he or she contacts the patient and encourages them to get those things done. So overall, this will benefit everyone. It's a win-win situation. Next slide, please. Other than these, a primary care provider's office can perform complete physical exams, cancer screenings, preoperative testing. Now that is very important. When you're undergoing an operation, a lot of times the surgeons don't even know what medicines you're on. So it is very important that you go meet with your primary care doctor who will look through all your medicines, look through all the tests you've had in the past, and tell you which are the ones you hold, which are the ones you continue to take, which are the ones very important that you restart soon after surgery. All that is extremely important. And then you have school physicals, camp physicals. Majority of school physicals and camp physicals are done on healthy people. So it may not look like it is a lot, but there are certain small nuances that we find out. If someone is allergic to something, we make sure that before that child or adult goes to camp, they have their inhalers, they have their EpiPens, or whatever they need when they're at camp. Or when they go to school, we make sure that the school authorities give them the medicines they need. If it's a child with asthma or ADD, or if it's just a child who needs medicine during school hours. So we do all that, we look into all that. Vaccinations, we make sure the child is vaccinated or the adult going to camp is vaccinated and protected. And like I said before, we do all the chronic disease management, diabetes, high blood pressure, high cholesterol, asthma, COPD, so that we manage them well. We see the patients every so often to keep them in optimal health. The goal being to avoid complications and to avoid patients having to go to emergency room or urgent cares. Next slide, please. Primary care providers are trained to care for newborns, children of all ages, and older adults. We take care of acute problems like respiratory infections, bronchitis, pneumonias, colds, and flus, as I mentioned. We provide vaccinations for all ages. We provide another valuable service that many people don't know. We give travel information and advice related to health. So if you are traveling to a country where there is a specific disease that's prevalent, we make sure that we look up the latest guidelines on CDC, the recommendations from CDC, and we make sure you're equipped with whatever you need for that travel. If you go to malaria-prone areas, we give you malaria prophylaxis to prevent malaria. We give you the right vaccinations for that country. We make sure you have some medicines for travelers' diarrhea. All this can be very important when you're traveling in an area where healthcare is not easily available. Next slide, please. Our goal is to diagnose conditions early and prevent long-term complications. As we all know, early detection saves lives. So at every point, at every physical, we are on the lookout for, is there any cancer lurking in the background? Is there any chronic disease that's not showing its head right now? And we plan accordingly. We talk accordingly, we advise accordingly, and we plan accordingly. In addition to these, we also help with end-of-life planning, a living will. These are very important. These are as important to elderly as it is to young adults and middle-aged adults. It is important that we plan the end of life and make a living will when we are in our right mind and right health. That way we can make informed and smart decisions. We give advice regarding all that. Some family physicians, some internists, and some APPs go to nursing homes to provide end-of-life care, and that is really great. Back in the day, we all used to go to nursing homes. We used to follow our patients to nursing homes, and that was very rewarding. But due to time constraints these days, we do not go to not all of us go to nursing homes, but there are some primary care physicians who still go there and help ease people's pain and keep them optimally comfortable during their last days. Next slide, please. I will stop here. Please note down all questions you have for me. After the next doctor's presentation, we will be back to answer your questions. Thank you all for coming here today and giving me this opportunity.
Okay, hello everyone, good evening. So I'm gonna go ahead and get started with the second part of the presentation. I'll be talking about cancer screenings as it relates to primary care and where to get different types of primary care and any other questions related to that. And again, after my presentation, we'll go back and answer questions. Next slide, please. Okay, and I also do have some animations on this as well, so I'll ask you to press if I need to. Okay, so the first question I want to answer is where we've already talked about what is primary care. So where can you get it? So there's various settings where you can receive primary care, and I just wanted to address the differences between some of them. The most common that you see around is what we call private practice. A lot of these designations don't matter quite so much to patients, except with regards to access and cost. So private practice is typically a private owned business that's owned by either a single or multiple physicians or advanced practice providers. Typically, private practices do not take uninsured patients, or if they do, there's usually a high cost associated with that, usually in the range of between $70 and $120 per visit. The next most common setting would be academic or center, which typically has trainees, which are typically residents and medical students. Now, just for purposes of the talk, medical students are still in medical school, and then residents are doctors who have completed medical school, but they're receiving additional training in their particular field of practice. Academic settings like Duke, which is basically all academic, in addition to having residents, they have what's called attending physicians or attending providers that supervise these residents. Now, they may either be supervised directly in that after seeing the resident, the attending might come in and say a few words and provide some additional information, or they may be supervised indirectly, and that's usually for residents that are further along in their training. Now, I work in a community health center. Also, another name for that is federally qualified health center. And the reason why it has that name or that designation is because it receives a portion of its funding from federal funds. There's some similarities between FQHCs and free clinics, but the main difference, again, is the funding. Free clinics are typically run by doctors on a volunteer basis. So they are not getting paid for working in free clinics, and you're not likely to see the same doctor over and over again. Whereas with an FQHC, you would have that continuity with a more often with one single provider. FQHCs and free clinics also see uninsured patients or underinsured patients, patients that have insurance, but it does not cover quite as many services as one would hope, depending on the type of insurance. Next slide, please. Okay, so what are the different types of care? Can you press the next button? Okay, so you may be asking yourself, what's the difference between primary care, urgent care, and emergency care? Okay, so we've already talked about what primary care is, both for treatment and prevention of disease. Primary care is the only setting where prevention actually occurs. Urgent care and emergency care and hospital care of any kind, you're not going to get any preventive services. They would direct you back to your primary care doctor. Now, urgent care is in between primary care and emergency care. Depending on, the facility, they may do some laboratory services and let's say find out they might be quote unquote screening for, let's say, diabetes or something like that, depending on whatever you're coming in with. Now, difference between urgent care and emergency care is that urgent care is not required to see you. Emergency rooms, emergency departments are required by law, by federal law, to see you. They are not permitted to turn you away for any reason, for cost or anything like that. But urgent care, there is typically a fee before they will see you. Now, it's generally speaking, depending on what it is that you're presenting with. If it's lesser acuity, it's better to present to either primary care or urgent care, just because with emergency care, because of the fact that they are required to see you, that generally slows down the care in the emergency department. And so if you have ever been to an emergency department and you're waiting there for hours, usually it's because the more emergent cases have to go in front of you. Now, one of the things that has changed in this state is that Medicaid has gone through a transformation in which it's now managed by various insurance companies. And so one of the reasons why they chose to do this is because there was no disincentive for, let's say, for patients going to seek emergency care, because the way it was set up before was that primary care visits had a copay, let's say, of anywhere from $15 to $20, maybe $25, whereas emergency care was free, at least for the patient, but that cost was then shifted to other patients or to the system or whatever the case may be. And so now there is now a fee associated with that, although it may be delayed, they may not have to pay it up front. We'll have to just wait and see what happens with that. Hopefully it doesn't have a secondary effect where it causes some people to delay seeking care due to costs. We'll have to wait and see what happens with that. This was a recent change within the last few months. Next slide, please. Okay, so how do PCPs assist with cancer screenings? As Dr. Pisharody mentioned, I'll talk about that in a second, how various types of screenings happen or what they're based off of. Most of the screenings in primary care have to do with organization recommendations. The ones that the organization that primary care providers follow most often is the U.S. Preventive Services Task Force, or USPSTF. But then if you could press advance, please. There are also screenings that are performed by age. Going back to organizations, there are other organizations that exist beyond that. There's one for gynecology, urology. There's pretty much an organization for everyone that you can think of. And the recommendations vary slightly based on the organization. For example, if you're old enough to remember this might have been 10, 15 years ago, when breast cancer recommendations was to screen at age 40, and then they changed it to 50, and there was sort of a big uproar about that. This is where some of the organizations dissented, and American College of Gynecology still recommends age 40 for routine screening. So screening is performed by age. So for example, cervical cancer, that doesn't start until age 21. The USPSTF actually recently changed its guidelines for colon cancer screening. That is now at age 45, whereas it used to be age 50. Age 50 has a grade, it's by grade. So A and B are the recommended screenings, and then anywhere from C onwards are ones that they're equivocal or not recommended. Next point, please. Okay, so screenings can also be performed by risk, and what I mean by risk is, depending on whether you're a man or woman. Let's say, so screening for this is not a cancer screening, but screening for abdominal, like aortic aneurysm, so enlargement of one of the largest blood vessel in the body, is only for men who smoke, for example. Or obviously men and women have different cancer risks, so prostate cancer screening versus cervical cancer screening. Or if you smoke, lung cancer screening is a screening that's only for smokers who have smoked a certain amount. Or if there's a family history of any type of cancer, and not just family history, but the age at which the family member had it. So if they had breast cancer, but your mom was 75 when she got it, then that does not necessarily increase your risk for breast cancer over the average person. But if they were 42 when they got it, then yes, you would most likely, instead of being screened at age 50, it would be 10 years before that person was diagnosed. So it's important to have that information for your doctor, letting them know not only that your family member had whatever cancer, but how old were they when not when they passed away, but when they were diagnosed. Next point, please. So there's also disease-specific screening. For example, in patients with cirrhosis, one of the cancer screenings associated with that is screening for liver cancer. Now, there are other disease-specific screenings that do not have to do with cancer. For example, diabetes, you screen for kidney disease, you screen for retinopathy or eye problems. Next point, please. So in addition to, PCPs being aware of, when a patient comes in, paying attention to their age and sex and family history and all those other things that would sort of bring it to the forefront of their mind, hey, this person is due for a screening. We also have assistance from electronic medical records. Duke and also Lincoln and many other practices around the triangle uses EHR called EPIC, or electronic health record. Here is an example on the right there. It's supposed to pull up as not just an alert for the provider, but also an alert for the patient if they're signed up for something called My Chart, which it will show what are your recommended screenings and what age you would be due for them. Obviously, it shows other things, including vaccines as well. I did want to add that I don't know if this has changed since there have been changes to the Affordable Health Care Act or Obamacare, but there should be a provision in there that covers the cost of screenings with an A or B recommendation. Next slide, please. Okay, so what are some challenges that are associated with trying to get cancer screenings? So one of them is time constraints, not only for the providers, but also the patients. It's very challenging sometimes to be able to perform urgent care and preventive care in the same visit. Some things might be addressed, some things have to be tabled for the next visit. But there's also, again, time constraints for the patient. Let's say if you're getting a colonoscopy, you have to take time off work because that might be sometimes an all-day affair. You have to, or even the night before, you have to drink the liquid to be able to clean your entire bowels out and then be put to sleep. And then, so that can be time consuming and actually, and there might be challenges with regards to transportation. There's also, for certain insurances, there might be a cost associated with preventive screenings. Or it might be that the initial test is covered, but if one of the tests turns up positive, they may not cover with quite the same level of coverage any follow-up testing. And then there's also some people might avoid certain types of screenings. I actually have a handful of patients where they've avoided certain types of screenings that are uncomfortable. Mammograms, this is a picture on the right of mammogram, but so mammograms can be very uncomfortable because it requires basically a pressing of the breast from both angles on both sides. And so, yes, I have had some patients avoid that. Now, there is some discomfort, let's say, or inconvenience with having to drink the liquid for colonoscopy. I will say that there are other screening tests for colon cancer besides colonoscopies. There's an annual stool test that does not require nearly as much time. Take the test home, you perform the test, you bring it back. Now, if it's positive, then you would need to proceed with a colonoscopy, and I'll get back to that in future slides. Another challenge with cancer screenings is, some patients, for whatever reason, whether it be cost or not having insurance or whatever the case may be, actually present with symptoms of whatever the cancer might be. And so at that point, it's no longer screening. Screening means you're asymptomatic, but then you have either a cancer or a precancerous lesion, or nothing at all. But if you have the symptoms, obviously, that's going to be more time consuming and costly and, emotionally taxing and all those other things. And obviously there's also challenges as well with, costs and all that with regards to uninsured patients, because it is harder to get cancer screenings if you are uninsured because there's no insurance company to cover the preventive costs. Okay, next slide, please. Okay, so what is the referral process for abnormal screenings? Can you press the button, please? So I just wanted to make a mention here that a positive test can be very anxiety provoking, but it does not mean that you have cancer. Screening tests are actually designed to have what we call a low false negative rate, in that a false negative is a test that shows up as negative, but it's actually positive. So they're designed to have a low false negative rate. So because they're designed that way, they have a higher, what we call false positive rate, which I told you what a false negative is. A false positive is a test that shows up as positive, but it's actually negative, or either you don't have cancer or you have a precancerous lesion, which that's not considered a false positive, but yes. Next slide, please. All right, so continuing this thought, I just wanted to specifically go over these 4 types of cancer screenings and the referral process for that. So for Pap smears, right now the screening recommendations for that is starting at age 21, between age 21 and up to 30, it's every 3 years. But after age 30, we can perform a DNA test that allows you to spread out that interval to 5 years. If you screen positive, but it depends on what is positive. It can either be abnormal cells, or it can be the HPV present. And that was the DNA test that I was referring to. So depending on what it is, there's different levels of this positivity. So it could just be, hey, the DNA was present, we'll just repeat it in 1 year to see if it clears. Or if there's abnormal cells, they can either be abnormal but low grade, or abnormal but high grade, as in high risk for developing into cancer. At that point, you would be referred to a gynecologist, and they would either perform like a procedure to remove those abnormal cells, or they would do a biopsy to determine, is this cancer versus a precancerous lesion. For colonoscopies, like I said, that starts at age 45 as of the last year or so. You have the option of getting it between 45 and 50. Typically for colonoscopies, it's every 10 years if everything is normal. And I also said that the other screening modality is called a FIT testing. I forget exactly what that stands for, but that involves obtaining a DNA sample from your stool. If a colonoscopy is positive, again, it doesn't mean that you have cancer, but you might have a precancerous lesion, a polyp of some kind. There's different kinds of polyps. Some are more likely to turn into cancer than others. So if it's a high likelihood, the interval for returning for another colonoscopy would be 1 year instead of 10 years. But the intervals vary, like I said, depending on the lesion type. It can be 1 year, 3 years, 5 years, or if everything is normal, 10 years. PSA, so this is actually has a grade C recommendation. So, but it's not a costly test. So PSA is a screening test for prostate cancer. We do not have a great prostate cancer screening test. There are many things that can raise your PSA, urinary tract infections, other things like that. But like I said, it's a low cost laboratory test, and it's a discussion to have with your doctor about whether or not you desire to have it. And again, if there's a family history of that, that's even more important. The cutoff varies by age, but generally speaking, the cutoff is like 4, where it's considered low versus high. If it's slightly elevated, let's say it's 6 or 7, the option might be to repeat it in a few weeks, or especially if there are symptoms present, maybe treat for some sort of prostate infection and then return for a repeat testing. Now, if the level, let's say, is greater than 15, that would probably warrant a referral to a urologist for further testing. Again, does not mean you have cancer. There are many things that can raise your PSA. Mammography, that's the standard screening for breast cancer. Now, one thing that I will point out is that it is there's a difference between a screening mammogram and a diagnostic mammogram. Screening mammogram is what is performed at 40 or 50, depending on what recommendations you use. If that is positive, then you typically what might happen is that you have a diagnostic mammogram, which is a lot more sensitive for picking up cancer than a screening mammogram. Which, if that's positive, and they may decide to proceed with biopsy, or depending on if the screening mammogram, again, that is by grade as well, the same way as it is for cervical cancer. They score it from anywhere from 0 to 6 being low likelihood versus high likelihood for breast cancer. So if the screening mammogram has a high score, then they may just decide to proceed with biopsy. Okay. Also, I just wanted to state as well that whenever you see your doctor and they mention getting, a screening test, make sure that the telephone number that you have is working, and if it changes within from whenever you see them to whenever you're supposed to have that test scheduled, make sure that you call your doctor's office back and know that let them know that you have an updated telephone number. Okay, next slide, please.
I believe that's it.
Okay.
Thank you so much, Dr. Kilgore. And thank you, Dr. Pisharody. Again, we'll hold questions for after LaSonia's presentation. I'm going to go ahead and introduce our next speaker. LaSonia Melvin Barnett is our Office of Health Equity Senior Program Coordinator. She is a certified patient navigator at the Duke Cancer Institute Office of Health Equity, as I mentioned. I won't go over her entire bio just due to time, but I will say that she has 16 years of in-depth history in patient navigation, which began through a National Cancer Institute Health Disparities Grant in Southern North Carolina that included prevention, screening, and survivorship. LaSonia has been with the Office of Health Equity for 2 years now, and she's doing an amazing job at leading by example. And I'm actually, she is my supervisor, and I'm very, very excited to have her come and speak with you today. So I'm going to go ahead and turn it over to you, LaSonia.
Nadia, thank you so much for that introduction. I am so excited this evening to be able to present on a topic very briefly that is very near and dear to my heart, and that's patient navigation, navigating the sea of cancer care. Next slide. So as earlier in the presentation, Nadia spoke about the vision and mission statement. So I just wanted to make notice of that, the mission statement again. So the mission statement of the Duke Cancer Institute Office of Health Equity is to reduce cancer disparities and promote health equity within Duke Cancer Institute's area of reach. And so we look at these 4 core areas when working and reaching to the community. And the one that I really want to focus on this evening is community-facing patient navigation services. Next slide. So what is patient navigation? Patient navigation, according to Dr. Harold Freeman, which is the founder of Navigation, is a community-based service delivery intervention designed to promote access to timely diagnosis and treatment of cancer and other chronic diseases by eliminating barriers to care. And the beautiful thing about our office is that our office has what is called community-facing navigators. So what that means is that even though we are located within the healthcare system, Duke's healthcare system, we also have the ability to create relationships outside of the healthcare system with community organizations and faith-based organizations. So you will find us within the community, especially now since COVID numbers are dying down. We have been released to go out and to become a part of some of the community events that are happening all across North Carolina. So our office is very excited about being able to go back and be a part and have relationships within the community, because we really, really miss that. Next slide. So social determinants of health, what are they? Social determinants of health are an individual's personal circumstances that have an impact, either positive or negative, on one's health and well-being. And so if we look at this illustration, we see that these are some of the personal circumstances that can impact a person's health. So if we look at family, the family that you were born into, you know, the genetics, what are some of the predisposed dispositions of the health conditions within the family. Those all affect a person's health. Their gender, this is something that was talked about earlier in the presentation, especially, Dr. Pisharody talked about, this as well. Education, a person's education plays a main role in one's health. Access to the healthcare system, one big one. Having clean environment. We don't think about that, but what we breathe in, where we live, in the house that we live, do we have exposure to radon? Radon, which is a substance that you can't see nor smell, but it could cause lung cancer. So you hear a lot of times about individuals that develop lung cancer and have never smoked a day in their life. It may mean that they have been living in a dwelling that has a high level of radon. Safe housing, does your house have maybe lead paint, that would affect one's health? Income, really, really big one. Can you afford to have health insurance? Some people choose to pay their bills and they cannot afford to have health insurance. So that is a great impact when it comes to one's health. One's race, we find that we have structural racism within healthcare systems that keep individuals that are historically marginalized not able to receive the care that they need, as well as a person's culture can affect a person's health and well-being. Next slide. So when we look at those social determinants of health, where you live, your family, your gender, all of these impact healthcare, and they cause barriers to arise. And so I just wanted to bring up or list a few of the barriers that we see in healthcare, or we see as navigators when working with individuals. Access to quality healthcare, that's a big one. I was on a call last week and I was speaking to some social services members that work with the community in the western part of the state. And they were explaining to me that, there are not a lot of federally qualified healthcare centers which take in individuals or see individuals that do not have health insurance or are underinsured. And she was explaining to me that a lot of those primary care providers and federal qualified healthcare centers no longer was existing and the providers had left the area. So therefore individuals would have to travel to other counties to seek care. So that was a huge barrier happening within the western part of the state. And if they had to go to another county, then that could bring another barrier. That could bring a transportation barrier that would come up. So one barrier can lead to another when working with patients. A lack of understanding of the healthcare system. I've been working in healthcare since 2005. Prior to that, I had my share of ups and downs throughout the healthcare system. And I had to learn how to go through and find out, how do I connect to care within the healthcare system. And it's definitely different when you're in a smaller healthcare system as opposed to a larger healthcare system. You know, I've been in a smaller healthcare system, but when I showed up on the Duke campus, I was so overwhelmed by the huge campus. And, you know, you can best believe that there are patients that are coming from rural areas that also are overwhelmed with the healthcare system. And therefore, there's a lack of understanding of how to get through the system. This is something that Navigators helps patients work on, and they navigate them through the system so that they do not fall between those gaps within the system, and so that the outcome is much better for them as they're going through their treatment process. So other barriers include cultural beliefs, structural racism, as I talked about before, finances, access to healthcare, citizenship concerns. Now that can bring about trust of the healthcare system because there's some individuals that are undocumented. And so I know that in past in dealing with patients that they were not willing to share accurate information, you know, about themselves because they were afraid that they could possibly be deported. Language, big barrier. Now, even when you're speaking the same language, such as English, with the way that one person interprets a conversation can be totally different from another. So sometimes it's good to get a better understanding, particularly with the provider and the patient, of what's going on. Sometimes we have patients that say they nod when they're in an appointment, and then the provider thinks that they understand, and then they go home and they are clueless to what the provider has told them. So these are all barriers, as well as cultural competency. So it's important for the provider to be culturally competent so that they understand the culture of the individuals that they're working with every day. Next slide.
And Sonia, just wanted to let you know we're at time. We have
Okay.
8 minutes for question and answer, but I
Okay.
will go ahead and advance the slide.
Okay, thank you. So we'll make this quick. So this slide just tells you some of the problems and some of the solutions that navigators have to figure out when working with patients. Transportation, an individual may have Medicaid and they don't know that they have access to Medicaid transportation. So we educate that patient. So these are different ways that we take a problem within the healthcare system when working with a patient and we find solutions. Next slide. So here are examples of navigation services that our office provides. We will assist patients with cancer screenings and finding a primary care provider if they don't have one. We also assist patients with finding financial assistance for cancer-related medical care. We direct patients to healthcare services for further diagnosis. And we also provide navigation guidance in and through the healthcare system. And these are 3 ways that we do that. Next slide. So what we want to say to you as the community and faith-based organizations, the Office of Health Equity, we are here for you to provide patient navigation services to everyone, regardless of insurance or documentation status, in order to be connected to timely cancer care. Next slide. Thank you so much for having me. What I would like to share with you is I'd like to send out a listing of our patient navigation one-pager that describes what our office does. And on the back of it, it has screening guidelines so that if you have not had your cancer screening, you know when you should have it. And you can talk to your provider about when you have the screenings based on, say, for instance, your family history and things of this nature. And we'd also like to share with you the Federal Qualified Healthcare Center listing of providers across North Carolina, and that's listed by county. So thank you very much for having me.
Thank you so much, LaSonia, for that. So we had a schedule packed of great information that we put together for you all. So thank you so much to our speakers, for today. I did notice that a lot of people had entered questions in the chat. And so we did have a question that Aretha Rice asked, but I will let the speakers go over some of the most important things that may have come up in the chat, and then see if anyone else had any questions before we get to the closing. So if our speakers could come on camera again. And I know you guys have been answering some questions, but if you want to point out any of the, like, some highlights from the questions you've been answering in the chat, and then see if anyone has any more questions.
There was a question from Miss Anita Rice about why should I go to see my primary care physician if I am not sick? That is a very good question, actually. Primary care is not only for sick people, it is also for prevention. As I was saying, prevention is very, very essential. Also, primary care physicians will assess your risk factors. And that is very important. I mean, we get a total history, we do a risk stratification, and we individualize care for you. That is why you need to see a primary care physician, even if you're not sick. You don't have to go often if you're not sick, but you should go at least once a year for a checkup.
Thank you so much, Dr. Pisharody.
Okay, and I wanted to add and expound on that too as well. So, you know, the definition of screening is that you don't have symptoms, essentially. And so in addition to these cancer screenings, we also do other screenings for, like, diabetes, for example. It takes actually somewhere in between 5 and 10 years before you might know that you have diabetes. But there's a pretty easy blood test that we do to check for diabetes. Now, most of our screenings start around age 40 or so, but it's important to try to get, you know, I guess your health in order as best as you can before then. So the question that I wanted to address, there was a question about liquid biopsies. So, you know, I'll read it. So there's an article in there. It says, when liquid biopsy came out, they were going to use it for early detection of cancer. However, fast forward to 21, this has not gone mainstream. Is that because it has a lot of false positives, or are there other reasons? And I basically said that the only liquid biopsy that I was familiar with, and hold on one second. Tell me if I'm pronouncing your name wrong, Regendra. If there are others, I haven't heard of them. So yeah, so that's essentially what FIT testing is, the fecal immunohistochemical testing, where they're looking for DNA of cancer or precancerous lesions in the stool. Now, this has become relatively more widespread because the stool test that was available before was actually for blood and not for DNA, and that had a lot of false positives. This, if it's positive, it's going to be DNA. So it's either going to catch cancer or a precancerous lesion. Now, if you wanted to add to see if there was other, you know, cancers that they discussed, I didn't find a specific cancer testing in that article. I did click on it.
Thank you so much, Dr. Kilgore.
So Nadia, do I have time to address one question?
Yes.
Okay, I want to address the question that one of the participants that registered asked, and it's, how can we best teach and share how to get in touch with a PCP to community members? Well, we offer a community health ambassador training within our office that gives great detail about cancers and symptoms and screening tests, as well as there's a portion of the training that explains how to educate community and faith-based members on connecting to primary care providers and ultimately receiving their cancer screenings. So if you are interested in possibly learning some of these skills and learning how to share this information, then please reach out to our office and we'd be happy to share the next class that should be coming up in October with you. Thank you.
Thank you so much, LaSonia. And I also included in the chat that I am bilingual and I'm also a patient navigator. So you can always reach to our office, and even other languages. We have a language line. So if you have someone that you want to refer to us, please feel free to do that. I also included my email. If we didn't get to your questions, we apologize. We had so much good information to cover today. But I did want to go over some upcoming events. We have a Henrietta Lacks event where we're celebrating Henrietta Lacks and building trust, the path forward. This is the flyer that we have. I can also drop that flyer in the chat. If you would like that, please just stay on after a few minutes after, and I'll do that in just a moment. The Office of Health Equity is also inviting you to our virtual series on blood cancers, which will take place on August 19th. And September 25th, we will have a men's health screening event. It's our largest event. We had 321 or over 321 men come to our last men's health screening, and we're expecting to have around that same amount or even more this year, especially due to COVID and people not having had their screenings. So please just keep these events in mind. Also, you have my email, so you can email myself or LaSonia if you would like more information on those, and we would love to get that to you. But I will go ahead and I stopped sharing. I just want to thank, if everybody can just do a reaction and do a clap for our speakers. They did an amazing job. We are so thankful for your expertise, for your passion, for the community, for your love for what you do, and how many people you have helped in your years of work as primary care providers. We truly thank you, and for also being in the front lines during COVID. I'm sure you've put in long hours, and we're just so grateful for what you do, and also for taking the time today, even after work, to bring this so important information to us. So a big applause to you and to LaSonia, because she has not stopped either all throughout COVID. So thank you, everybody. Please feel free to contact us if you have questions, and we would be happy to connect you to more information. Or you can also search these providers to see if they're taking new patients. I know a bunch of you are probably in love with them and want them as your primary care now, so you might find them as well. But again, thank you, and have a wonderful evening, everybody.